you're live.
Thank you very much. Good afternoon, everybody, and a very warm welcome to the April public board meeting of the Wye Valley NHS Trust. I'm delighted to welcome you on behalf of our chairman, Russell Hardy. Colleagues who are familiar with the organisation will know that because we are in a group structure across Herefordshire and Worcester, and with colleagues in South Warwickshire Foundation Trust and George Eliot, I chair the board as Frances Martin Vice Chair on a quarterly basis, very ably supported by our Managing Director, Jane Ives. We also note apologies from Glenn Burley. People who are familiar with the NHS and some of the changes happening nationally may know that Glenn has recently been appointed as the National Financial Reset and Accountability Director. This is obviously going to take a significant amount of his time, and therefore to enable him to fulfil his responsibilities, we have appointed two new interim chief executives, Stephen Coleman for Herefordshire and Worcestershire, and a colleague doing the same in Coventry and Warwickshire. So they will support Glenn by relieving him of some of those accountable officer roles, but that doesn't change the day-to-day running of the organisation by our executive team led by Jane Ives. We also note apologies from Andy Parker, who is our Chief Operating Officer, and are grateful that Sarah Cinder, one of his Associate Directors, is here in his stead. I don't think we have any other apologies. So has anybody got any declarations of interest like to be noted for this meeting? I can't see any digital hands, so we will proceed. Moving to the papers in front of us, the notes of the minutes from the 6th of March. Has anybody got any amendments or additions that they'd like to make to those minutes? The one small one from me, I wasn't at the meeting, but on page 406 in my pack, it says that our morality figures, I think that's a small typo and should be mortality. Spell check won't pick up things like that. So if we could amend that, Val, but I don't think I had any other changes. The action log, which is on page 13, no actions to be brought forward to this meeting. So therefore we'll move to the next item, which is the Managing Director's report, and again a minor typo, it's calling the Medical Director Jane. I know that there are many strings to your bow, but I don't think you'd want to add that one at that point. So what would you like to pull out of your report?
Thank you. Thank you, Frances. Yeah, and it's always good to know our morality is as expected, isn't it? It's a rapidly changing environment that we're in at the moment. Obviously, the NHS reset, which sort of came about really 3 or 4 weeks ago with the changes announced to NHS England and the changes to the top team, means I think there's a very rapid change approach to the scale of the challenge that we're facing nationally, but obviously that's all locally as well. So since writing my report, we've now had a letter from Jim Mackey, the new Chief Executive of NHS England, when he took over 2 days ago. So I thought I'd highlight 1 or 2 of the things that were in that. So first of all is that the national deficit, which was forecast in our planning around for 25-26 to be 6.6 billion. The work that's been done over the last couple of 3 weeks has reduced that to a national plan deficit of 300 million now, and obviously our own financial plan, which is now forecasting to live within our deficit agreement, is part of that. But that does mean the scale of the challenge that we have, along with the rest of the NHS, is really very significant. So last year we delivered about a 4% cost and productivity improvement plan, and about half of that was non-recurrent. To deliver our plan this year, we'll need to deliver about 6%, and we'll need to deliver about 80% of that on a recurrent basis. So just to give this the scale of the challenge, but that is our intention to deliver on that plan. The other thing that letter talked about was the intention to move the NHS away from deficit support and back to a fair shares approach. And we know in Herefordshire we've always had that problem of rurality, but we do now have about £14 million, and we are expecting more from our Welsh commissioners, direct to our bottom line to support that rurality challenge we've got. But that move back to fair shares and the removal of deficit support for Hereford and Worcestershire equates to a number of about over 100 million that our system will lose over the next time period, and that's yet to be agreed, but we expect that to be stepped down over a number of years and certainly not in a single year. The other thing that was announced was that reduction of ICB funding by 50%, and what Jim Mackey's letter set out was the changes he expected to see from integrated care boards, and then to move into a strategic commissioning role only, and so all those issues and things that they deal with in terms of performance management would move across to NHS England and ultimately to the Department of Health as NHS England moves into that new structure. And as part of that also is that requirement to reduce any corporate cost growth that we've had over the last few years by 50%. And some of that will accelerate some of the things we were doing already across the group, which is how we can deliver some of those back office functions more efficiently across the group. So there's an awful lot of work to do around all of that, and it's part of that broader challenge. The last thing that was set out in the letter was around, and people may have seen this, that the cap on elective activity, it suggests that there won't be a cap on elective activity. However, it does need to be agreed with Commission, so it's a little bit unclear at the moment. But what we have right now is an activity plan, which means that we will deliver the national target, and that's all within the budgets that we've set out. What has come slightly left field to us, though, is the notification from our Welsh commissioners that from Q2 they are expecting Welsh patients to be treated to the Welsh standards, which is a maximum of 52 weeks for outpatients and 104 weeks for routine inpatients. That's quite a long way from the English standards, where there's a 52-week expectation by the end of next year. So any of our Welsh patients who've got an appointment booked with us now, we will see them, but we can expect, and those patients can expect, that they won't be getting their treatment that was planned over the summer, and they may well be delayed because of that commissioning change. So we'll communicate with patients, but anybody who's got an appointment now should come and receive their treatment. So moving on to a few other things then. So we've had, since the last time we met, the results of the National Staff Survey, and we've got a paper on that on the board later with some of the detail, but really delighted that we'd started off in quite a strong place. We've improved a little bit further over that. So that's really good news. And what's been really good actually is that the feedback about our managers has been particularly strong, actually, and the way that staff feel about their leadership and management teams. So that's something that we'll keep working on, keep making sure that we're improving the experience of staff. And then the last thing I probably want to talk about was our work with our partners in Herefordshire. So we have our One Herefordshire partnership, which has been going now for the last 4 years. So we had our 4th annual review last week, which was a positive meeting across partners, where we reviewed our progress over the last year, and there's some things to celebrate, but also set out our ambitions for the coming year. And I put into the paper around the neighbourhood health guidelines. Those have been produced nationally about how we're going to make 2 of those shifts that are going to be in the NHS 10-year plan, which is from treatment to prevention and from acute to community services. Really, how we're going to deliver that is how we work in our neighbourhood teams with GPs, with social workers, with social care, and with the voluntary sector. So there's some dedicated work going on over the next few weeks just to finalise our plan for that, and then that's going to be part of how we work in the coming year, and that's particularly important for urgent and emergency care to really reduce the demand of for urgent care. So last thing we've got on the report is just from the medical division, just their update on things that are going on in the medical division. And other than that, I'm happy to take any questions.
Thank you, Jane. As you say, a very busy agenda for everybody locally and nationally. So thank you for condensing that so eloquently. Any questions or comments for Jane? No, in that case, shall we move forward to the integrated performance report?
Yeah, so a few introductory remarks on this. So this really is that time of the year where we're starting to look forward as well as looking back on our previous performance. So looking forward again on the board agenda today, we've got our trust objectives for the coming year and our quality objectives. So setting out the things that we are aiming to achieve over the coming year. Looking back, urgent and emergency care and the overcapacity in our urgent system continues to be our biggest problem performance-wise, but also our biggest problem financially. Looking back, and one of the things we did when we did the review with our partners in One Herefordshire was to look at what's happened in terms of emergency demand. And what we can see is over the last 2 years, we've had about a 15% increase in the number of admissions of patients who are aged over 65. So that's really the big driver of that. So our approach and the prioritisation of work that we will have with partners and internally will all be about how can we reduce that emergency demand, and that will be about supporting more people at home, either to prevent them becoming ill in the first place, or to provide more of their care at home and less of it in the acute setting. So that continues to be our biggest problem, and Sarah might want to talk a little bit more about the work in our community services and the work that we're doing there. Really good to see our theatre utilisation really improving now. We've had some real sustained improvements. So February is at 83%, that's the highest we've ever had. So our target's still 85, we want to get above that, but a really good sustained improvement. I want to say really is actually if our ophthalmology specialty came up to the average of the others, actually we'd be at 85%. So we've got a specialty review with our ophthalmologists in the next couple of weeks to go through what it is that we need to do to move their utilisation up, and so we can treat more patients waiting for their eye surgery. I'll ask Jeffrey to talk about healthcare support workers when he's doing his update. We've made some really good progress on healthcare support worker turnover with a number of interventions we put in, but actually that seems to have reversed itself out over the last year. So Jeffrey, really keen to understand what we're doing about that and how we can get that back to those previous levels. So at the next meeting, I'll do sort of a bit more of a review of looking back on this year that we've just finished. But I'd like to sort of end on some positive things. So our waiting lists and our waiting times for patients are significantly down. Our cancer improvements are up, mortality is down, and that improving staff survey, I think, are all things that we can be really proud of. But we've also got an awful lot of challenges to face in the coming year.
Thank you, Jane. agree with all that, and our ambition is to provide the very best care that we can for the people of Herefordshire and Mid Powys, and applaud all of our teams for the progress that they've made, as you've described. Any immediate questions for Jane, or should we move to the detail of the report? Okay, move on, thank you. So quality, Lucy Chizzo, what would you like to pull out?
Thank you. Just 3 things from me, and then I'll hand over to Chizzo for the mortality. So I just wanted to start with Ross Community Hospital. They've had an ongoing outbreak of CPE since last year. We have been, as a trust, under intensive support from NHS England, and NHS England and ICB colleagues visited Ross Community Hospital earlier last month to do an assurance visit, and I'm really pleased to report that we've been able to lift the outbreak status at Ross Community Hospital. They saw really good improvement in infection prevention control practices and environmental cleanliness. And they singled out Beth, who is the matron and lead for that community hospital, for her leadership to get the hospital into the place that it needs to be. So we're in a monitoring phase now, and we're hopeful that with the continued hard work that we'll be able to close down that monitoring phase by the end of May. Included in the report are the high-level patient-led environment assessments, the PLACE results. They were published during February, and these are just the high-level results. The arrows within the tables are just monitoring whether we have improved our position compared to last year or deteriorated, and also included in the high-level results is the national benchmarking and where we feature in relation to that. We need to do some more detailed analysis, and that's the next phase for us. We need to understand why, compared to last year, Ross and Leominster have deteriorated their position, and we need to get underneath the detail in relation to that. And in particular, we need to focus on the 3 domains where we stubbornly do not make improvements year on year, and that's in particular around privacy, dignity and well-being, dementia and disability. Some of the progress is hindered by our estate. So, for example, we score you obtain scores for having accessible toilets in every clinical area, for having prayer rooms in every clinical area, and for having quiet spaces for patients and or relatives to have conversations and to sit and relax. Clearly, given the pressures, given our capacity issues, we aren't able to offer that, and therefore there are some things that we won't be able to address. But we know there are things that we can do, and therefore we are going to focus particularly on privacy, dignity, wellbeing, dementia and disability moving forward, and that'll be overseen both through our patient experience committee and also through quality committee as the year progresses. You can see within the PLACE results that actually our food scores are marginally better than last year, but we know we've got an awful lot of work to do in relation to food, particularly on the county site, where we know through other feedback sources such as the national survey and through complaints that we're not where we need to be in that respect. And then finally, from me, I just wanted to touch on, Jane alluded to them already, it's that time of year when we set our quality priorities for the forthcoming 12 months. These were shared in draft at Quality Committee in February, and then were taken for a more final discussion at our meeting last week. We've set 7 priorities, they're detailed in the slide. Some of them are a refresh of priorities that we had last year. We're just going to change the scope and focus of those. And some of them are brand new priorities, and I just want to touch on a couple if I may. So we will have a diabetes safety priority for this year. That's brand new for us. We know that diabetes treatments are complex and the safety around that is vitally important. With the CHISO supported leadership, we've developed a new diabetes safety forum and established terms of reference for that group. I alluded to in the PLACE results that we've got lots to do around food experience, food quality and food offer, and therefore we will take a priority forward around food this year. We had a really successful focus on time critical medications, particularly Parkinson's medication, during the previous year. And we've said we'll move that priority forward this year in relation to other time critical medications. We're going to focus on transition, and by that we mean transition of young people transitioning from children's services into adult services for next year. And we've just had a workshop this morning in our board around our volunteer offer and our desire to expand volunteer services and roles within the organisation, and how valuable they are for the individuals who volunteer themselves, but also for our patients and our staff. So we had a workshop this morning, and it will be one of our priorities as we progress into the year. I'll hand over to Chizo now for mortality.
Thanks, Lucy.
Thank you, Lucy. So our mortality indices, which is the 12-month rolling shimmy that gets us up to 2024, remains stable at 100. And what this means for us is that both our observed and expected deaths are similar for the people that are in our care, which is really pleasing to see. So when you look at our large outlier groups, we have shown improvement in fracture neck of femur, where we were an outlier. We're still not where we want to be, but it shows that the quality improvement that is well undertaken is bearing some fruit. There's also been improvement in sepsis and also stroke, where our shimmy is actually less than 100, suggesting that we have less than expected deaths in our service. Our perinatal mortality, the extended perinatal mortality, which covers both stillbirths and early neonatal deaths, remains high at 6.8. It's pleasing, though, to see that in the last month we've had a reduction in our stillbirth rate. All deaths are subject to both internal and external scrutiny. And we have been working on quality improvements, especially on improving prediction of preterm and also standardizing growth charts, especially for our women who live out of area. Thank you, Chair.
Thank you very much. Any questions or comments for either Lucy or Chizu? Ian.
Thank you. It was just to pick up on the place audit results that Lucy mentioned, which we discussed in some detail at Quality Committee last week. And absolutely, we need to focus on the domains of dignity, privacy, dementia and disability. However, my main point I wanted to make was actually to congratulate Bromyard Hospital, which had actually improved its scores across the board in all the domains. And it's actually now the top scorer among the services provided within the trust. So I thought, while there are things there we need to address, it's only right that also we should give some credit to Bromyard Hospital.
Absolutely. Thank you, Ian, for bringing that point, which it's very easy for us to focus on the negatives, but there's some fantastic work and real progress happening in certain areas. Thank you. Thank you, Lucy, for raising about volunteers. There are a number of items on this afternoon's agenda that the board covered in more detail in the workshop this morning, and we know that Herefordshire is a county that is outstanding in its community engagement and the willingness and appetite of people to contribute to their local community. So we currently have something over 100 volunteers. There are opportunities in every sector and type of activity that you think might happen in our services, which is just about every opportunity that there is. And we're currently revising the way that we make it easy for people to be able to volunteer for us. And so do encourage people to think about that. And shortly we will be making some more proactive approaches to the public through the media so that people can understand how they might be able to help and support their local health services. So, but we're very grateful to the team who are currently supporting us, and for Natasha, who's the Associate Director, works in Lucy's team, who's been leading that work and is owning this board priority for us. Any other questions or comments? No, thank you very much. So moving to activity performance, Sarah, what would you like to pull out for us?
Thank you. So yeah, I just wanted to pull out a few elements really just based on the paper, some examples of where our teams are providing a service outside of our hospital sites, but a really important part of our trust in terms of trying to reduce demand into our acute hospital. So I wanted to focus specifically on 3. So we've got our community referral hub, and you may or may not remember that last November we were able to expand that service. And what that's meant for us is that we've now got a GP 12 hours a day, 365 days a year, who are actually co-located in with our community referral hub staff. And what this then provides is that they were previously virtual, but they're now on-site co-located in that true MDT approach, so that our patients are getting the best decisions made about them. Where we've noticed that's made a difference, because that's the important bit for us to look at, is that making a difference? So the difference is really noticeable in our referrals from our ambulance service. So West Midlands Ambulance refer patients in for us to be able to go out and see in the community. But there's also another element of those patients that have called an ambulance has turned up at their house. The ambulance service are preparing to convey that person into the emergency department. But we've now got this opportunity for the paramedics that are on the scene to say, actually, is there another way that we can manage this patient rather than taking them into hospital when they might not necessarily need it? And that's where that GP comes into their own. So the paramedics have a direct line then to our GP in the hub. They can have those clinical conversations, and then the outcome of that conversation is we can absolutely keep this person at home, and we're going to send the most appropriate person out within 2 hours, so keep them at home. Or we think there's an opportunity here, you know, we're going to try to keep them at home, but we may have to send them in for some certain diagnostics, but then please send them back. Or actually there are those patients where the clinical conversation, the outcome is that patient needs to go into hospital, but please bear us in mind when they're ready to come home. So we're just starting to notice those really significant improvements and increases in those referrals from WMAS, and we'll keep going with that, because we think particularly based on Jane's comments around the over 65 patients in our communities, there's more to go at there. So that's high on our agenda, but it's really good to see a sort of demonstrable improvement in where we've put in additional resource. And then the third thing really was just about virtual ward. So we've expanded the virtual ward. It's taken us a little while to try and get the occupancy up, but we're really starting to notice that sort of consistent occupancy. And particularly we've in the last sort of 4 weeks been able to start admitting surgical specialty patients to those virtual wards, and in the main they're patients that have got trauma and orthopaedic specialty needs. So it's good to see that that's increasing, and it's just a case of sustaining that from here on in. So despite all of that that's going out in the community, and as Jane's already alluded to, we are still dealing with a congested emergency department, and we are still relying on using those temporary escalation spaces in our acute hospital because patients haven't got a bed to go to in a timely manner. So with that, we're looking obviously at now at our 25-26 plans. What more can we do to improve that? What more can we do to decongest? So along with the stuff that Jane's already alluded to related to neighbourhood health guidelines, we're also looking at what more we can do in the ambulatory space in terms of our same day offer. So there's a scheme related to that. The schemes are included in the papers in the full programme. And we're also doing quite a bit internally around our internal patient flow. So really making sure that we do as much as we can in the morning. So patients are best if they go home in the morning, get them home for lunch. And so there's a real big push on all of us that are involved in not only on the acute site, but those of us that are in community to make sure that we can make that patient flow happen as early in the day as possible. So there are our main focuses. Just 2 other brief things to mention. We've done an awful lot of work on our discharge pathways and the way we work in Herefordshire really closely with our local authority, so with all our colleagues in social care. We've made significant improvements in our patients that are delayed waiting to be discharged. So those patients that are absolutely ready for discharge, they should be home, but they're not because they need something. So that's running well. We've got pretty much all of our pathways set up, and we're starting to really notice the benefits of that. So our attention for the coming year really is to focus on POWIS, because our POWIS patients that come into hospital and need to get back to POWIS wait an awful lot longer than those patients that wait to go back in Herefordshire, and we really need to focus on that group of patients to make sure they get the same chance to get home when they need to, because we all know, don't we, that it's better that patients get home as soon as they can rather than waiting in hospital. And then finally, just a bit about elective productivity. Obviously, Jane's already alluded to the theatre utilisation, so I won't expand on that too much, but there's a load of work done, particularly in terms of those lists starting on time and finishing on time, so we didn't have early finishes. And what that's doing is obviously maximising our opportunity to get more patients through on our theatre sessions. I'm happy to take any questions.
Thank you, Sarah. An awful lot going on, and again, just to thank all of our teams that have made such significant progress on reducing waiting times for patients. We continue to apologise for the long waits that some people experience, either through our emergency pathways or in an elective way. And as you describe, anything we can do to keep people well and to be able to take care of them at home rather than necessitating a hospital admission will be in the best interests of patients, either themselves or other people waiting for care. Any questions or comments for Sarah? Very comprehensive. Keep up the good work, and yes, there's an awful lot for us to do working with colleagues across One Herefordshire to make sure that we're combining our efforts to look after people as well as we possibly can. So thank you. So Geoffrey, what would you like to pull out in terms of our workforce?
Yeah, thanks, Francis. We started to see a reduction in sickness absence, and we are revising the absence policy and bringing in place some more high impact actions, because we are determined to get absence to below 4%. And I'm confident that the changes that we're bringing in will help us to still be able to support our employees, but also reduce sickness absence to below 4%. Considering the operational planning guidance for 2025-26, we are ramping up our efforts to roll out e-rostering to all clinical groups, including medical staff. So over the next 12 months, we will be really pushing forward the drive to get e-rostering across the organization, because that's one key element of trying to optimize the use of your workforce and become more productive. So we're doing that. With April being Stress Awareness Month, we are actively encouraging all our line managers to get behind the national campaign, which is about leading with love and compassion. So we encourage everybody to get behind that and support our employees and ensure that we are still looking after their health and well-being. So we're doing that program. We've got a concern with healthcare support worker turnover, as Jane mentioned. And when you analyze the details, it's very clear that over the last few months, we've seen an increase in the turnover for our healthcare support staff. So the intelligence we have does indicate that through exit interviews, that it comes down to line managers making the time and the efforts to offer that pastoral care support, certainly within the first few weeks and first few months of those individuals joining the departments. Speaking of line managers, their concern has been operational pressures has had an impact on their capacity. However, we are speaking to divisional leads to ensure that we make the time to look after our support staff. So managers have been called upon to ensure that they make the time, and they also use other individuals within their teams to try and look after those individuals. So that is the plan for us, to try and reduce our turnover of our support staff, and also working actively with our practice education leads, so we can also offer that support through practice education. But ultimately, it comes down to our managers doing a little bit more and utilizing other people in their teams to support those individuals. So based on those things, those discussions we've had, I am confident that we will then see a reduction in that turnover for support staff over the coming months. Final thing I would just say, Jane mentioned the staff survey. It is on the agenda, but I'm very proud about the good results, and that just shows that our efforts in HR, OD leadership is having a very positive impact. So I'm really happy about that. Those are the points I wanted to cover. Francis, happy to take any questions.
Thank you, Jeffrey. Any questions or comments for Jeffrey? No. As I say, it is a concern, isn't it, the turnover rate in healthcare support workers, and I think there's something about managers and teams being very clear in the expectations of the role before people start with us, and then that support, because for many people it is an environment that is very new to them, and we want people to feel supported to do the best job, and we certainly in some areas have got a very low attrition rate of people that stay with us for a very long time and find it a fulfilling career. And I'm sure Lucy would want to say that it can, for those people that want it to, be a stepping stone into progressing through other nursing and healthcare roles, if that's what people want to do. So I think that's imperative that we get a stable workforce going forward. Thank you. Okay, moving on. Katie, what would you like to pull out about our financial performance?
Thank you, Francis. So board members will have seen the detail from a month 11 perspective through the recent Financial Recovery Board, but I'll take the paper as read and just pull out a few key points for today. So as we've described in the paper, and as Jane has already alluded to, the focus over recent weeks has been primarily working through the National Planning Guidance and what that means from a Wye Valley financial and operational plan perspective for 25-26. That process has now concluded from a national submission perspective, and the detail will be discussed later in private board, and then we'll come through formally in public board in terms of the usual final plan paper. In terms of the month 11 position, so the end of February, which is included in the pack, we have a year-to-date adverse variance to plan of £8.4 million, and that's stabilised slightly compared to previous months, which was what we would have expected as part of our route to reaching a forecast outturn position across the system. In February, we did pleasingly see a reduction in the use of high-cost agency spend, and partly because we saw those really significant operational pressures from January ease slightly. And year to date, we've delivered just under £13 million of cost and productivity improvement savings. In terms of that adverse variance to plan, so as I've described, we are expecting that to further improve towards the concluding the end of the financial year at the end of March, and that's as a result of implementation of a range of mitigations that we've discussed and agreed across the system, including the Trust taking some further stretch in terms of improvement, which we've run through divisional control totals effectively and divisional targets through to year end, and corporate teams within that as well. As we know, and as you'd expect, the Financial Recovery Board has kept a real focus in terms of delivery, both of that forecast outturn and those mitigating actions, and particularly now over recent weeks, moving that focus primarily to making sure that we're really ready for 25-26 in terms of CPIP delivery. So making sure we've got ownership, identification and clear plans for delivery for the new financial year. Just in terms of capital and cash to round off today, so from a capital perspective, we did see a step up in February, which we expected, linked to timing of some of the bigger programmes towards the back end of the year. And there is a further large amount expected to conclude during March, linked primarily to the new diagnostic centre, where much of the large equipment is scheduled to be delivered and come into our ownership in March, and then the investments around frontline digitisation, for which funding was only secured later on in the financial year. From a cash perspective, it has remained stable, and I think compared to where we thought we might be at the start of the year, cash has become less of a challenge during 24-25, and so thank you to the teams for their really close management of that. We do remain concerned around cash though as we move into 25-26, given the challenging nature of the financial plan, so we will keep a tight grip on it and continued oversight through board.
Thank you, Katie. And for reassurance for our staff and members of the public, we have a separate board financial recovery scrutiny process. That means we are close to more of the detail than is possible through this public forum, and therefore this isn't news to board members, but an important part of our governance that we report it in this way. Any questions or comments for Katie? Kieran, you're still on mute, Kieran. It says you're not on mute, but I can't hear you yet. Apologies, I don't think we can take your question, but we will come back to that later if that's possible outside the meeting. Any other questions or comments for Katie? I'd just like to thank Katie and the team because it has been a very difficult year. I'd love to be able to say that's fine, it's all going to be better in 25, 26. Unfortunately, it isn't. But the approach of trying to get ahead of the curve. So although some of the detail about the precise numbers and some of the national processes are to be determined, we know that we have a very significant financial challenge for the year ahead, and reassuring to know that the divisions and directorates are clearly sighted on that and are working on their plans to get best value for money and live within the resources that we have at our disposal, and everything that we can do to work with colleagues across the system to avoid duplication and expensive treatment options when we could and should be intervening more quickly is all of the work that we are prioritising going forward. So thank you, Katie, to you and the team who, on behalf of the organisation, are pulling it together. There's always a tendency to say that finance directors spend all the money. You just have to account for it to us. So we do understand the whole organisation effort that has gone behind balancing living within our means and continuing to focus on quality and access that are so vital to our core purpose. Okay, let's move on. Kieran's question wasn't vital, so I'm sure we'll pick that up separately. So, Alan, thank you for your work on trust objectives. What would you like to pull out of this paper for the board today?
Thanks, Chair. I'll take the report as read. We've talked about these extensively in the past in a board workshop in January, and they've been subject to a fair amount of engagement. They're the annual organisational objectives that form the basis for objectives for the exec team, for our divisions, and for wider teams. The document contains the overarching sort of graphic that we will use to promulgate these around the organisation. There's some narrative for each one and a bit of information on how we'll demonstrate progress. I won't go through them all, but I'll just highlight some of the recurring themes and a continuing focus for the organisation, which includes, and you won't be surprised to hear any of these having just gone through the performance report, urgent and emergency care, reducing elective referrals, financial sustainability and the transformation programme that goes with that, and improving IT functionality. There are some new topics in here as well, and again relates back to something that Lucy discussed earlier, which is around food quality. We have a new objective in here around testing out AI within the organisation, and that's a key part of our transformation programme. Tackling sickness is something that Jeffrey's already talked about today, and actually growing our volunteer workforce as well, who are a tremendous help to the organisation, and we think we can go further with that as well. Many of these will be delivered in conjunction with our One Herefordshire partnership, and in fact they're key to delivering some of these. We can't do some of these things alone. And what we'll do is we'll report back as usual mid-year on progress on these, and there'll be an annual sort of roundup within the annual report of the organisation. And that's it from me, Francis.
Thank you very much, Alan. And as you say, the board has been, and our colleagues through the Trust Management Board have been instrumental in developing these objectives, so they're not new to us. Has anybody got any questions or comments? No, so we are asked to approve them. If anybody is not happy to approve them, please raise a digital hand. I can't see any digital hands, so approved. Thank you very much. And as you say, Alan, a very pleasing, logical read through to our priorities and the risks. So it feels like we're doing the right things. So thank you for that. The next item is to review our standing orders and standing financial instructions. Colleagues may feel that this is a little dry, but it is imperative as a publicly accountable organisation that we have a system of probity that enables us to be clear on who has authority and responsibility for doing what and in what way. Gwenny, Katie, what would you like to pull out for the board's particular attention?
Mainly that these have been reviewed in detail by the audit committee. You've got the changed version on the track changes. They are a standard document. They are consistent with the other two of the other members of the foundation group of the Star Trust rather than foundation trusts. And the only changes bring it up to date with some of the more recent guidance in relation to standing orders. And Katie might wish to make a reference in relation to the SFIs.
Thanks, Gwenny. So just on the SFIs, again, primarily some minor reference updates. The one change we have done is we've reinforced the requirement for a contract adjudication report for contracts over £100,000. That aligns with the work we're doing with the procurement service in terms of good quality contract management and links to the Procurement Act, etc. So just to strengthen our clarity in that area.
Thank you. And Nicola, as Chair of Audit, is there anything that you were particularly concerned about in the discussion, or are you happy to support this?
Not at all. We've fully reviewed and I'm happy to support.
Thank you very much. So if anybody isn't happy, please raise a digital hand. No, I see no hands, so thank you very much. It's the sort of thing that people don't need to look at until there's a problem, so thank you for putting in place that provision that is the how-to guide for colleagues across the organisation. Thank you. Moving to the Quality Committee Terms of Reference and Forward Plan, Lucy.
Yeah, I'll be very brief. This is just the annual review of the Quality Committee Terms of Reference and that forward plan for the forthcoming year. There are only minor adjustments made to the Terms of Reference, so the quality priorities that were agreed at Quality Committee last week have been dropped into the Terms of Reference. And we've revised the subcommittee structure in light of that new diabetes safety forum that we've developed, and we've also added in a medical devices committee. So the subcommittee structure has been added and can be found in the Terms of Reference. The forward plan just shows how the committee will oversee the entirety of the work related to quality and safety throughout the forthcoming year. It may be subject to minor tweaks as the year progresses. These were discussed at Quality Committee last week and recommended to come to board today for final approval.
Thank you, Lucy. Again, a reminder for staff and for members of the public, the range and breadth of items that come under the quality agenda is such that we dedicate a very long committee once a month chaired by my non-executive colleague Ian to go in detail through all of these things so that we as a board can be assured that we are providing the quality of care that we want for our families and our friends. So it's important that these are right, and I know that Ian was part of that discussion. Is there anything you want to add, Ian, or happy that these come forward for approval?
Perhaps just to say that the Quality Committee priorities, what I would say, they're areas of particular focus for Quality Committee. They're not the only areas of focus, and there are lots of other quality areas that we will continue to scrutinise through the work of the subcommittees.
Absolutely. Thank you for that, Ian. So if anybody isn't happy to approve the Terms of Reference and Forward Plan, will you please raise a digital hand? Duly approved. Thank you all. Okay, we now move to the section of the agenda with items for noting and information, starting with an update on our ambitions for a new education centre. Alan, not the happiest report you've ever written. What would you like to pull out for the board's attention?
No, not at all. Obviously, this was a major capital scheme that we were expecting to take forward, and I was anticipating bringing a full business case to the December board. In initialising the costs and the borrowing around that, we found that the interest rates had increased in the time between developing the outline business case and the full business case, making the case unaffordable at that point. We took the decision to pause the project, although we had got to the point where we'd almost finalised it and were working through the planning application. And so we've continued to support the planning application, and we expect to have a determination on that from the planning department at the end of April. We also paused charitable fundraising, which many of you will know that we've been doing around that. And what I would say is we are at an advanced state of preparedness if we can find funding for that. So that needs to be the focus for us now with this particular scheme. So we've paused it. We need to find a new source of funding, which we intend to. We've got a number of leads we continue to work through, but in the current environment, it's quite difficult to identify that right now. The key thing for me is about communication with stakeholders. All sorts of people involved in this particular project. I particularly wanted to mention the charitable trusts and individuals that have pledged their support to this scheme. And I think it's vital that we communicate with them and tell them where we've got to with this scheme and that we're pausing it because we've had an awful lot of support from them for this. So that's it from me, Jen.
Thank you, Alan. And second, your thanks to the people who've worked so hard. This is a pause. This is not the end of our ambition. It is absolutely vital for us in Herefordshire that we have the best facilities to train our teams. We know that people who have good, it's an enormous incentive for recruitment and retention, and some colleagues are working in very cramped and unsuitable conditions currently. So we're still absolutely committed to this. It's just we don't have a suitable financial solution for it at the moment, but it's not going to go away from our commitments for the future. Any questions or comments from board colleagues? So thank you to Alan, and we support the decision to continue with the planning application. One of the particular strengths of Alan and the team that he leads is our ability to have business cases ready to roll when suddenly there is an opportunity. So we need to be in a position whereby we can push the button at a future date without having to go back to the drawing board. So hopefully that will be supported by the planning committee this month. Thank you. Jeffrey, we've talked about the staff survey. We all know that the most critical measure for us and the most significant information that comes across our desk is the staff survey, and very pleasing that we continue to make progress. There's an awful lot of detail in the report, and I know that colleagues have had a chance to read that. What particularly would you like to bring to the board's attention?
Well, thanks, Francis. I mean, as you say, the staff survey is one of the most important measures which tells you how the organisation is functioning and gives you that temperature check. And as Glenn said, it's the most important measure that he looks out for on an annual basis. So the survey results largely back to 2023 levels. So broadly, from a national perspective, the 2024 results are very similar to 2023, and most of the themes within the elements of the people promise are now back to the pre-COVID-19 pandemic level. And we've seen some good results from a national perspective in areas like compassionate leadership, health and safety climate, appraisals, work-life balance. However, from a national perspective, there are also some concerns about the levels of violence from the public towards members of staff, and also the levels of unwanted sexual behavior towards members of staff. So those are some of the key things from a national perspective that are of concern. Also, some of the equality, diversity, and inclusion indicators have worsened. They're not getting better. So that's also a national concern. But overall, it's been broadly similar results to 2023. From a Wye Valley perspective, I am pleased to say that we are still maintaining our good, strong performance in all areas of the survey. And in fact, when you look at some of the scores, we are closing in on being amongst the very best in the health service, so we can all be proud about that. We have some areas of concern as captured in my paper, which we are working on. But all in all, there's no area where we are rated as being amongst the worst in the health service. So I think that's something we can really be proud of. It does show that the interventions we've put in place are making a positive difference for our employees. There are some notable areas as well, which I think it's worth mentioning. So the feedback from staff in terms of their line managers is very positive, and I think we should really be proud about that, because ultimately our line managers help us attain our key objectives. We've also still seen some good feedback in terms of staff engagement, staff morale, people having a voice. So the whole Freedom to Speak Up program that we have is working well. And work-life balance is also a good area. We are still maintaining our position as the second best results in the group, and we are still intending to close down on Swift even more over the coming year. So that's the aim, that's the intention. And from a group perspective, it's also worthwhile to say that our engagement scores in the survey are amongst the best in the NHS. So that's really something to be proud of. So all in all, I would say still really strong results for Wye Valley. We know we've got some areas to work on. We will be relaunching the In Touch staff engagement campaign over the next few weeks, working with divisional managers. And we're going to run that local engagement program over the next 3 to 4 months, where we will be working with local leaders to address some of the areas of concern within the survey. And we will continue with our HR, OD, and leadership programs, because those are having a positive impact. Those are the key points I wanted to pull out from the survey, Francis. Happy to take any questions.
Thank you, Jeffrey, very much. Jane.
Yeah, so yeah, really pleasing set of results. The only thing that isn't pleasing is our response rate, which is about 34%. So 1 in 3 staff responding to a survey. I mean, it's a good chunk, and so the results are meaningful. But we will this year get those results above 50%. So a number of the executives here who are responsible for large numbers of staff, it's going to be in their personal objective this year. Other organisations manage 50% and above, and so can we. So we will make sure we get that response rate higher, because the more staff that respond, then the more accurate it is.
Absolutely support that, and in the same way that we're competitive with our colleagues across the foundation group, I'm sure there will be some competition between divisions and professional groups, so you can take that challenge. Nicola.
Yes, I say, Jeffrey, I was going to say what Jane just said about volumes. Jane got in there first. Absolutely mirror what you said there, Jane. Second one, I just want to say well done, because I think stepping forward at a really difficult time, in a time of change and uncertainty, with that backdrop, I think we shouldn't underestimate the fact that we've moved forward. So thank you, Jeffrey. I say you've put so much work into this. And the third bit is looking at that, the violence and sexual violence and general violence increasing, also looking at that racial abuse increasing. I think we can be quite protected at our level in terms of what's the detail of that, what does that look like for somebody on the front line, and what does it mean to them? Because I think we probably need to be a little bit more aware and open our eyes to what that looks like, so we can understand what we need to do to try and put that right and make sure that's something from board level down that we really get behind. So I'd just be interested in understanding more about that and what we're going to do about it in due course. Jeffrey, I realise this is still pretty much the beginning, so thank you.
Thank you, Nicola. Grace.
asking what we can do to mitigate it until we can take the actions that we need to take. Because obviously we don't want to normalise anything, and at the same time this is clearly a problem that has been increasing over time. So what mitigations or support can we put in place in the meantime while we are continuing this work?
Yeah, absolutely. And I'm sure Jeffrey will consider that as part of the what do we do about these results now that we've got them. Jeffrey?
Oh, absolutely. That is something that we will be looking at, working with our colleagues as well and our staff networks and also staff themselves to see what other ideas they may have. I must also say that at the national NHS CPO meeting this week, I raised the concerns as well from a national perspective, and they will be coming back to me. The question I posed was, are there any organizations where they're not seeing the difficulties in terms of violence, harassment, and also the EDI elements? Do we have organizations whereby they are doing well in those areas? And they couldn't answer that. So they will come back to me on that, and I'll feed back to the board once I get the answers.
Thank you, Jeffrey. Enormously complex, very pleasing to see the trajectory, but absolutely we need to hear from more people. And just to reiterate for all staff, it is unacceptable for people to feel victimized or harassed because of any of their personal beliefs, attributes, behaviours, or any other trait that they are displaying, and we will not tolerate that. It is a minority, and we want all our staff and all of our patients to feel safe in our care. So that is without question. So thank you, Jeffrey. Really good work. And of course, any of the objectives for the executives you've got the overarching ones. So I'm sure Jane will make that clear in your objectives in terms of the compliance and the completion rate for the survey. Thank you. Okay, well done, keep it up. Thank you very much for that. The next item is the safeguarding annual report. I said earlier that a number of the items on this afternoon's agenda were discussed this morning, and we were grateful that our colleagues from Safeguarding Children came and presented a case study, and we undertook some preparatory training as a board around our awareness and compliance with safeguarding policies and procedures and understanding how the system works. And that is imperative for all of us, but also for all of our colleagues within the organisation. It is a whole trust responsibility to safeguard all of our patients, whether they are children or adults. The report was discussed through Quality Committee, but Lucy, what would you like to pull out for the board this afternoon?
Certainly. So you've alluded to the workshop this morning where the board level training took place and some of the trust responsibilities that are required in order to safeguard children, young people and adults. One of our statutory responsibilities is to produce an annual report for children, young people, adults and children in care. And so that's what you have in front of you. We're going to be brief here because, as Francis has already alluded, not only have we done that in the board workshop, but we look at this agenda in detail at Quality Committee every quarter, and the annual reports are just a distillation of those quarterly detailed reports. But we are really pleased. This is complex, niche work, but we're really lucky to have 3 great teams for adults, for children, young people and for children in care. They're fully recruited too. We've got an expanded offer within the multi-agency safeguarding hub. Since the last annual report, we've employed a domestic abuse lead and set up the domestic abuse service, which is really positive. And what I think these reports actually demonstrate is really good multi-agency working, because actually we can only safeguard children, young people, adults and children in care by working in partnership with the relevant agencies. I'm happy to take any questions, Francis.
Thank you, Lucy, very much. Questions and comments for Lucy? No, very clear. And as you say, we have scrutinised this every quarter and then the annual report through Quality Committee. So please thank the team again for their absolute commitment. And as you say, this is a Herefordshire-wide commitment. We are all corporate parents taking the responsibility for safety and for the protection of all of our citizens. So thank you very much and keep that up. Next item is Perinatal Services Safety Report. Back with you, Lucy.
Back with me. So the monthly reports sit with me, and then we normally invite leaders of the service to do the quarterly reports. This is just the standard monthly report, and it's really nice to be sat here to say I've got nothing to report by exception to board that's of concern, but some really positive things in there in terms of full recruitment to our services and the teams supporting the maternity service, some challenges within the neonatal workforce, but safe and experienced neonatal nurses, doctors looking after our children that are cared for on our neonatal unit. Just a note on the maternity incentive scheme year 6, you'll recall last time we met as a board that we confirmed we'd submitted our self-declaration to the scheme. That scheme won't publish formally the outcomes of those self-declarations until later this month, but we're hopeful that they'll endorse our self-declaration of compliance with 10 out of 10 standards. And just to confirm that year 7 of the maternity incentive scheme was published earlier this week. So we're currently just digesting what's different for the scheme this year so that we can work towards achievement of a further 10 standards this year. So given there's nothing by exception to report here, I just wanted to say that the safety champions, of which Francis, Sharon Hill and myself are the board level safety champions, we have a monthly safety champion meeting and a monthly safety champion walkabout. And those walkabouts are really well received by the staff working on our neonatal unit and across our maternity services. And staff are able to talk to us about all of the things they are proud of. And they would also be able to raise concerns with us should there be any that we needed to report through to board. Happy to take any questions, Francis.
Thank you, Lucy. Very comprehensive. Any questions or comments for Lucy or for Sharon and me in our safety champion roles? No? Okay, thank you very much indeed. Gwenny, use of the trust seal.
This is just here for information for the board to note that the trust seal was used on a document which was a license to install service media.
Okay, we duly note that. Thank you. So moving on to the receipt of some committee summary reports and minutes. Firstly, the Audit Committee report and minutes from December 24. Nicola, anything you want to pull out for the board?
No, it was a much shorter meeting than usual because we threw in an extra meeting to cover a few internal audits. So that's why there isn't an awful lot, unless anyone's got any questions.
Thank you, Nicola. Questions or comments for Nicola? No, thank you. Then Quality Committee, Ian.
Nothing to add, Chair. You have my summary report there and the full set of minutes. Happy to take any questions.
Thank you. Any questions or comments for Ian? Again, as previously noted, many of the board members are part of Quality Committee, so we will have been part of the discussions at the time. Thank you. Then the Charity Trustee report and minutes. Grace.
Thank you, Chair. The report is there. Nothing to highlight to board or pull out, but happy to take any questions.
Any questions or comments for Grace? No, I don't see any digital hands, so thank you. And then finally in this section is the integrated care exception report, and I chair that report, but thank you to Gwenny for producing the report on my behalf. Any questions or comments from colleagues? No, obviously self-explanatory. Thank you, Gwenny, for that. Oh, Jane.
The comments on the format, actually, which is sort of a testing out of a new format in terms of assurance report. So maybe not for now, but just people consider whether they like that approach. It seems to me to be sort of a really simple way of looking at assurance. So it might be something we might want to consider for some of the other assurance reports. So just for people to go away and think about.
Second that. Hopefully it gives people a very visible and succinct way of understanding the issues and the level of concern. So yes, questions, feedback to Jane and or Gwenny on that as a format, which I think would be helpful. Thank you. Okay, then we move to any other items of business, and I haven't been notified of any. Nope. And in terms of questions from members of the public, I think we did have a question, but it wasn't specifically in relation to this item, and therefore we don't need to take it now. Is that correct, Gwenny?
Yeah, that's right. It was more of a problem to solve, which has been dealt with directly.
Okay, that's reassuring. Thank you. The acronyms are there as usual. When in doubt, I'm sure that the list will need updating at some point because we invent new ones all of the time, and grateful for colleagues who try not to use acronyms without a definition of those included in reports. We do want our meetings to be accessible for members of the public who aren't embedded and enmeshed in NHS speak all of the time, as inevitably all of us are. So if there are no other items of business, thank you all very much for your continued hard work. We're now into a new year, amazing how quickly they come around. And so onwards and upwards, enormous amount of challenges, but also opportunity and enormous faith in the whole team to be able to rise to that opportunity as we continue to strive to provide the very best care that we can to support our staff and to live within the means that are at our disposal. So can I suggest that we take a few minutes and reconvene again for items of a confidential nature not suitable for discussing in public at 2:20. Thank you all very much indeed.